All right. Hi there, everybody. We are going to go ahead and get started. Thank you for joining us, first of all. This is our webinar, The Marathon After the Sprint, Ensuring Value and Equity in the Future of Telehealth. Just a reminder that this is the first of our two-part series on this topic, and it'll be focused on the equity portion. You can sign up for the second portion, focused on value, on our website, and that will be taking place next Tuesday, the 15th. That's me. My name is Annalisa Johnson. I am a policy and communications analyst here at Altarum's Healthcare Value Hub. Now, before we get started, there are just a couple of housekeeping rules I'd like to go over. So all lines will be muted until our Q&A at the end of this, and then you'll have the option to unmute yourself to ask questions. We will give you those instructions later, so no worries. We're eager to hear your thoughts, and remember that you can always use this chat box to type in questions that you have. We will only be able to hear you if you have dialed in via your phone. The audio info should be up top in the right-hand corner of your screen. And remember that this webinar is being recorded, and it will be posted on our website for people who are unable to join. So please keep that in mind when you're asking your questions. If you do experience any technical difficulties, please reach out to my coworker, Elise Lowry. You can see her email there. It's Elise, E-L-I-S-E, .Lowry, L-O-W-R-Y, @altarum.org. We also have a hashtag for this event if you want to follow along on Twitter, and that is hashtag telehealthequity. So it's no secret that COVID has rapidly hastened telehealth adoption, both among patients and providers. Part of this new demand is due to the stay-at-home orders and also desires of patients and providers to have fewer in-person appointments when appropriate out of safety concerns. The ability to provide telehealth has also been helped by federal and state policy changes, making it easier for providers and patients to engage in these practices by loosening restrictions on telehealth coverage, establishing more equal parity between telehealth and in-person visits, as well as waiving or reducing copays for certain populations. While these federal and state policies have expanded access to telehealth, they've also raised questions about equity in the current telehealth usage and in the future of telehealth. For example, telehealth can create a digital divide between upper to middle class patients who receive most of their telemedicine by video and between patients such as the elderly, different racial and ethnic groups, and people who have low socioeconomic statuses and who tend to receive most of their telemedicine by telephone. We need to ask ourselves, what does equity in telehealth look like? Are the people who would benefit the most from the advantages of telehealth able to take advantage of this, or do barriers remain to access and usage? In the future, when these temporary policy changes revert, will telehealth become even more inequitable? In this webinar, our speakers will discuss their own research and experiences when it comes to equity in telehealth, as well as the promise and downfalls we could face when trying to ensure an equitable future. Without further ado, I would like to introduce our wonderful lineup of speakers. They include Lee Taylor Penn, who is a senior policy analyst at Families USA, Dr. Elaine Kuhn, an assistant professor at the University of California, San Francisco, and Ian Hill, a senior fellow at the Urban Institute. Without further ado, I will go ahead and let them get started. Lee, you are up first, and I will toggle to your first slide.
Hi, everyone. I'm Lee Taylor Penn, a senior policy analyst at Families USA. Families is a leading national nonpartisan voice for healthcare consumers that is dedicated to achieving high-quality, affordable healthcare and improved health for all. At Families, we house the Center on Health Equity Action for System Transformation, the only national entity exclusively dedicated to the development and advancement of patient-centered health system transformation policies designed to reduce racial, ethnic, and geographic inequities. One of the projects within the center is our Evidence for Equity initiative. This initiative is focused on identifying and promoting representative and transparent evidence to help decision makers transform the health system in a way that advances health equity. As part of this initiative, families partnered with the Patient-Centered Outcomes Research Institute, or PCORI, to translate the results of PCORI studies into actionable and clear policy recommendations for state and national advocates and policymakers. Our final report in this project focused on telehealth's role in responding to the COVID-19 pandemic and provides state-level telehealth policy recommendations to improve health outcomes and ensure health equity during the crisis and beyond. As you all know, the COVID-19 pandemic has changed patients' treatment needs and the ways they interact with the healthcare system. It has also changed providers' care delivery structures as they adapt to new delivery methods to serve patients and stay financially solvent. This massive shift, telehealth services has tremendous potential to improve health equity. However, health advocates should not assume that provider use of telehealth during the pandemic, when there is little choice, will shift healthcare delivery permanently. States must make the necessary policy and regulatory changes to make telehealth accessible to all and to help providers make the transition to telehealth permanent. So in the report that we put out earlier this summer, we focused on state policy recommendations on equity and telehealth in 3 priority areas: improve financing and implementation, remove provider barriers, and improve patient access to telehealth services. The continued provision of clinically appropriate telehealth services past the emergency period is especially important for residents of rural and frontier areas, people in communities disadvantaged by social and economic injustice, individuals with severe chronic conditions or disabilities, those with behavioral health issues, and people without reliable access to transportation. Evidence from PCORI and many other research studies supports the effectiveness of telehealth in meeting patients' treatment needs and addressing health inequities, particularly in the areas of chronic disease management, mental health care, and remote patient monitoring. In this report, we used 3 PCORI studies as a foundation for, as I said, state policy recommendations organized around these 3 themes. So financing telehealth services is a key component in improving access to care for low-income and vulnerable populations. But it's important to consider how the finance service or model in question will affect health equity. For example, while most states have provided payment parity between video-based telehealth and in-person care, access to audio-only services is itself a critical policy goal. According to the Pew Research Center, 96% of the population in the U.S. has a cell phone of some kind, but fewer than 40% have the video capabilities necessary to participate in a telehealth visit. So we must ensure service parity between audio, video, and audio only to make sure that patients without a video-capable device can still access these services, and we can also guarantee equitable reimbursement for providers who serve these patients. Financing can also improve health equity by ensuring language interpretation services for limited English proficiency telehealth patients. Currently, only 15 states directly reimburse providers for language services. But direct reimbursement would offer more incentive for providers to secure telehealth platforms that allow for integrated language interpretation services, ensuring that these are more accessible for LEP patients. You can also see the other policy recommendations that we have here. So priority number 2, removing provider barriers. Healthcare providers experience a variety of barriers that prevent the integration, adoption, and use of telehealth capabilities, including a lack of investment in telecommunications infrastructure, the need to redesign old clinical care models to accommodate telehealth, malpractice policies, interoperability, and a varied state regulatory framework. So as I'm sure most of you can think, that a lot of smaller providers are facing barriers to adopting telehealth capabilities. But a 2018 survey of U.S. hospitals found that less than half of the respondents provided telehealth-based services. So it's, clear that providers and health systems have had to adopt telehealth very rapidly. But they're facing a lot of logistical barriers beyond just reimbursement. And it's important that states collaborate with these providers and health systems on issues like enhancing telehealth infrastructure and building capacity to deliver evidence-based telehealth services. And when implementing grant programs or specialized assistance programs for providers and health systems focused on telehealth, states should prioritize those that are serving the most vulnerable patients, like Medicaid providers, safety net hospitals, and those located in rural or frontier areas. And then the final recommendation is around bridging the digital divide to improve patient access to telehealth services. COVID-19 has made it clear that access to the internet is a determinant of health. Families are relying heavily on digital devices for their education, health, and social needs. I'm sure a lot of you participated in a Zoom holiday over the past couple months. However, people who are older, have less education, or are from under-resourced communities such as tribal nations are less likely to have access to these technologies. And in addition to access, some other contributors to the digital health divide include knowledge, skills, and even confidence regarding the use of these tech devices. So one strategy to address the digital divide is for states to require Medicaid managed care organizations and or providers to utilize direct support professionals, such as social workers, patient care coordinators, and community health workers to work with patients to teach e-health skills and literacy. In a PCORI study on patient activation for low-income people living with HIV, participants showed an improvement in e-health literacy, patient activation, and involvement in care after participating in intensive group-based training. So this improvement in e-health literacy was associated with important health outcomes, such as fewer ED visits, fewer avoidable hospitalizations, greater adherence, improved decision-making, better experience of care, and a reduction in disparities. And minority participants showed the greatest gains in e-health literacy. I also want to talk about the elephant in the telehealth room, which is broadband access. While access to broadband will require large-scale federal and state investment, there are a few stopgap measures that are being implemented, including the Federal Lifeline Program, which provides phones and discounted data plans to low-income consumers, and the use of CARES funding by states to establish free community hotspots, such as equipping a school bus with Wi-Fi and driving it to a central community location. So in closing, thank you all for this opportunity to speak with you today, and I hope that you will read our report linked here, and then also consider signing up for our Health Equity Action for Transformation, or HEAT network. Thanks so much.
Awesome. Thank you, Lee. That was wonderful. And just to remind everyone that we will be providing links to those great resources that Lee just shared in a follow-up email that will be provided to everybody once our webinar is complete. So now we can move on to our next speaker. Dr. Kung, you are up. Feel free to unmute.
Great. My name is Elaine Kung. I'm a professor at UCSF, and I also clinically provide primary care at San Francisco General Hospital, which is our safety net hospital in San Francisco. I'm really excited to be with you all this afternoon and to follow up Lee's presentation, which I think sets some really excellent groundwork for a lot of the issues that I'm also going to touch on today. So I think, as will probably come to no surprise to any of you all here, there has obviously been a huge adoption in telehealth. And what I want to point out with this slide here, which is data from our safety net system here, is that we basically sort of overnight went from providing no telehealth care, which is in the orange, to providing sort of the majority of our care in telehealth. And really most of these services, as we mentioned, in our safety net system actually were phone-based care. We're probably providing less than 5% of our telehealth visits right now through video. And I think the other thing to point out is actually because a lot of our patients, with shelter-in-place orders and only really needing to access their phone, is that actually utilization has gone up in a lot of the community health centers that were providing telehealth care because our patients are answering the phone. And part of this that is concerning is because a lot of safety net systems, as mentioned before, really weren't using telehealth care previously. And so I just did a quick Google image search of patient using telemedicine. And as you can see, sort of the vast majority of these pictures here, right, it's somebody in front of a laptop. They're really nicely situated. They've got sort of an ideal telemedicine video environment. And that's sort of not the reality of any of my experiences with any of my patients. And so we were really worried when, we first transitioned over to telehealth and that video-only services were initially reimbursed at the same rate as in-person services, that this was going to really pose a barrier for a lot of our diverse, vulnerable patients. And so what we did was early on in the pandemic, so we looked at the data from the end of February and compared it to some of the data at the end of March to the beginning of April. And so the data pre-COVID is in blue and the data post-COVID is in orange. And we looked at groups that we were really worried might have access issues with getting to telehealth care. And so what you can see here in the groups, the older patients, patients with limited English proficiency, lower income patients, and really the vast majority of the populations of color, we see a drop in their utilization. And in particular, I want to point out the Medicare population here. Before COVID, they were nearly 40 to 45% of the visits during that time period. And after the initial conversion to telemedicine primarily, they went down to only 20 to 25% of visits. So that's a huge drop in utilization in a very vulnerable group that does need chronic disease management. And part of the reasons that we were really worried about these are a lot of the things that were outlined in the policy solutions in the presentation before. So the first, of course, is simply having access to devices. So while the overall U.S. population, does have high rates of smartphone ownership, we know it's much lower in lower income individuals, people with limited educational attainment. And so having a device is simply obviously necessary to have any type of telehealth care. In particular, not just a video-enabled device, but also having blood pressure monitors or other types of devices that enable really high-quality telehealth care. This is really an issue for a lot of our lower-income patients where payers actually don't reimburse for these services, and so it's hard to provide higher quality telehealth care. If a patient has a device, they still need to have high-quality data access. And this is in particular a concern for a lot of our lower-income patients and populations of color, where we know that they are increasingly what we call smartphone-dependent internet users. So people who access and use the internet, but really only for their smartphone. And so if that's their only data access, we don't really want to burn through all their minutes or all through their data access just through a 20 or 30-minute video visit. And the lastly is something that we call digital literacy, or we refer to as e-health literacy, is somebody's ability or confidence of really being able to use devices. For example, I had a patient who had a smartphone, and I asked, would you be able to access the internet from your phone? And she told me she couldn't, but when I looked at the phone, she actually had an Android phone. So these are folks who maybe have devices and could, in theory, get onto a video visit, but actually don't have the skills to do sort of a number of the sort of the digital functions needed to get access to telehealth care. And these are not just sort of theoretical barriers. We surveyed about 200 of our patients in our safety net system, and I want to note here that our survey here had nearly 90% of the individuals identified as persons of color, and over 50% were limited English proficient. And so the first thing I want to point out is there is really large interest in this population. 2/3 of our patients were interested in having a video visit over a phone visit, but only about 50% were able to successfully complete a video visit, and over half of our patients reported barriers to getting on telemedicine visits, video visits. And these were related to device access, confidence in using technology, and inadequate data. And in particular, inadequate data or inadequate Wi-Fi was the most commonly reported barrier amongst our patients here. Speaking from my experience as a clinician too, there's a number of barriers that are particularly prevalent in community health centers and safety net systems. The devices are an issue also from the clinician side. You know, I work in San Francisco Health Network, and we're relatively well-resourced safety net system, and we're only now just getting videos into our clinics to be able to provide telemedicine video visits. So all the video visits I've done have been on my own smartphone. There's also issues with really needing to put in financial investment to get a HIPAA-secure video platform. With the changes in policies during the public health emergency, this was waived and made it a little bit easier. Folks could use FaceTime and programs like that. But moving forward, systems really will have to invest in a HIPAA-secure platform, and this is something that, of course, costs money. And I think lastly, there are just suddenly a new wealth of skills and rules needed for members of the healthcare team. So supporting patients in getting on to a telemedicine visit, thinking about how do I provide high quality telehealth care, what's appropriate for telehealth versus what needs somebody to come in person. These are all things that are new, require our time, and of course require financial investment to be able to support, for example, a nurse or a social worker in actually providing the technology support to help our patients access this care. So I think some solutions that we're looking into and that really align with some of the policies identified before is, I think at a very basic level, is that health systems should be encouraged and should be actively looking for patterns of disparities. This is really the first step in all disparities research, is you can't help address disparities if you don't go looking for them. And there's a movement in thinking about including equity metrics and pay for performance measures, and this is sort of one way to think about it, is just ensuring that folks are accessing care equally. The second solutions, and these are really clinician focused, are actively screening for barriers. We should expect that some of our patients are going to have barriers, and we should try to proactively address them. These include, do they have a device? So really asking practical questions that all patients will understand. I often have to give examples. Do you have an Apple device, or do you use FaceTime? These are things to help understand what type of devices they have. Asking if they have enough data access. So reliable internet access, do they have an unlimited data plan? And then trying to assess digital literacy issues. So asking if they've used apps before, if they feel confident using their device on their own. And beyond digital literacy, some folks are going to have other barriers. So for folks who, for example, live in really crowded settings, they may not have a private area. Individuals who are unhoused may not have a private location. And thinking about individuals who also may be in a relationship with domestic violence, they may also be worried about having a telehealth visit as well. We also are thinking about how to connect our patients to resources if we do identify barriers. So as was mentioned before, both for device access and data access, there are FCC Lifeline programs in California. There's a specific website, but the National Digital Inclusion Alliance also has a nice listing of broadband access. And then to address digital literacy, I think this is a lot more challenging. There's a lot of community organizations like libraries, for example, that do help train individuals in using computers or technology. And then internally, what we tried doing are things like developing resources for diverse patients. So we have Zoom trainings in multiple languages for patients who might need that additional support. And then I think lastly, I'll just sort of briefly run through this because this is probably better highlighted by a number of the other speakers. But I think policy changes are crucial. So thinking about reimbursement for devices, not only to actually have the visit, but to also support home monitoring and also the different types of visits that are needed. As well as in safety net systems, really these teams are doing a lot more to support those patients and getting access to telehealth and thinking about how do we reimburse for that time. In health systems, of course, doing all the things that I just discussed, and in particular, making really inclusive design decisions. So initially, when health systems were adopting platforms for video visits, some of them didn't allow a third-party individual. And so that effectively excluded any patients who, for example, needed a language interpreter or an ASL interpreter. So really thinking about making sure decisions make your care accessible to all populations. And then lastly, as we talked about, as just briefly highlighted before, is thinking about how do we translate high-quality team-based care into a remote world. There's a couple of resources which I think will also be shared in the email afterwards, and we'll be happy to take questions after all the presentations.
Wonderful. Thank you so much, Elaine. That was fantastic. Yep, as Dr. Kuhn said, we will be providing those resources, so no worries if you weren't able to sort of scribble them down quickly enough. We're going to go ahead and move on to our next speaker, Ian Hill. Ian, I'll let you go ahead and unmute and tell us what you're going to...
Okay, can you hear me now?
Yep, we can hear you.
Okay, great. Hi, everyone. It's really a pleasure to be here, and thank you, everyone at Altarum, for including me. I'll be presenting today. Our paper's called Maternal Telehealth During the Coronavirus Pandemic, Equity Concerns and Promising Approaches. The Urban Institute, for those of you not familiar, is a not-for-profit policy research organization. I'm a senior fellow in the Health Policy Center, where we focus our evaluation and analysis on health coverage and services for vulnerable populations and individuals and families. And I've focused my career on maternal and child health programs, Medicaid and CHIP, among others. This research was conducted as part of the Transforming Healthcare Initiative at the Robert Wood Johnson Foundation. So I want to thank the foundation for its support of our work. And I also want to thank my co-author, Emmy Burrows, for her equal contribution to this paper. See here. Okay, just as background, let me just state what everyone probably already knows, that there is a maternal mortality and morbidity crisis in America. About 700 women die each year during pregnancy, delivery, or within a year of delivery, and many, many more women experience severe maternal mortality during this period. Our outcomes, like they are in so many cases, are among the worst of most high-income countries around the world. Let me also say that there are stark racial and ethnic disparities that persist in these outcomes that grow from deeply rooted systemic racism in our health systems and society. Specifically, the maternal mortality rate for Black and American Indian women is 2 to 3 times higher than the rate for white women. So the emergence and rapid spread of the coronavirus in 2020 created this imperative for social distancing, as we've all discussed, as well as an imperative for delivering healthcare remotely, virtually via telehealth. It was true generally, and it was also true for perinatal care, which I define as prenatal delivery and postpartum care for this paper. You know, we think that this shift has resulted in remarkable ingenuity and advances, but it's also raised the question of whether or not telehealth is improving or exacerbating maternal health inequities. Let me just say a couple of things about, there we go. Sorry about that. I'm managing through my slides here. Let me talk a little bit about the project and its methods. This paper was developed as part of this larger series of papers we wrote this year about the pandemic and its effects on maternal health equity. For those papers, we conducted a series of individual and small group interviews with about 40 stakeholders over the summer, spring, summer, and fall. These included maternal health experts, perinatal providers, consumer advocates, funders, and frontline health workers. We also conducted ongoing comprehensive scans of the literature, both formal and gray, which we were constantly updating given the rapidly emerging information that occurred all year. We asked folks about what promising maternal care telehealth practices were emerging during the pandemic, what access and equity concerns were arising, and what early lessons could be applied to the delivery of maternal health care in the post-pandemic future. One limitation I want to mention is that because of social distancing, we could not consider recruiting women for focus groups to obtain their input directly. So while not ideal, our interviews with providers, frontline healthcare workers, and consumer advocates are our imperfect proxies for those voices. So keep in mind that our findings are preliminary and reflect early insights during this very rapidly changing environment. Okay, so let's talk about the promising developments that have emerged. As others have already said, the pandemic really spurred rapid changes in policy around what services could be provided via telehealth, what providers could render care virtually, what communication modes could be paid for, video, phone, text messages, what is paid for telehealth services, and how HIPAA privacy rules apply. The providers and stakeholders we spoke with were generally pleasantly surprised by these changes and how well they worked, given the crazy situations under which they were all working. During our interviews, they noted that most of their patients had smartphones, just as the data you heard, concurs. They had smartphones, if not computers, so reaching women via telehealth was not as problematic as they expected. Indeed, many providers reported that attendance at prenatal care visits had improved during the pandemic, and this was because of both the increased convenience of telecare as well as the elimination of traditional barriers such as the lack of transportation or affordable childcare. Some providers said that group prenatal care sessions were much better attended than before the pandemic, and that telehealth could really be a game changer for the provision of postpartum care, which has traditionally had has notoriously low attendance rates. And overall, patient satisfaction seemed pretty high overall with the visits that were occurring. Continuing with more promising developments, as others have underscored, telehealth expansion was really facilitated by federal and state governments, which declared the public health emergency and then showed a lot of nimbleness in creating new service, reimbursement, and privacy policies. State Medicaid programs followed suit and expanded coverage of telehealth for different services and providers. They enacted payment parity requirements between telehealth and in-person care, and not only for Medicaid, but also for private health insurance through their state insurance regulation. In our paper, we write about examples in California, North Carolina, and New Jersey. We also learned of several private sector organizations and initiatives that are offering telesupport for maternal care services. We write about a program called MAVEN in Massachusetts that's under contract with the Medicaid program there to provide virtual fertility and pregnancy care. We write about Baby Scripts, which is a virtual care platform that provides wireless blood pressure monitoring, weight monitoring, educational messages, and appointment reminders. We write about some hospital-based initiatives, actually at UCSF, the RESPECT initiative, and at Penn, the Pregnancy Watch initiative that scaled up telehealth-based platforms for pregnant women. And finally, we talked with folks and talked directly to several community-based programs that traditionally and intentionally provide hands-on care in the home, places like Ancient Song Doula and Mama Toto Village in Washington, D.C., that also have successfully transitioned to virtual care. They're not 100% happy with it, but they've been able to make the switch. I want to put in one little plug, if I may, about improved value. I know that's the topic for the next webinar, but I thought maybe I'd prime the pump for that discussion by saying that with regard to perinatal care, it's traditionally thought of as a high-touch type of care where providers need to carefully observe rapid changes in maternal and fetal development and carefully monitor blood pressure, glucose, weight gain, and whatnot. But concerns around COVID-19 and the spread of the virus have really led providers to reduce reliance on interventions that have long been thought to have questionable benefit and value. So what we've seen are actually fewer unnecessary inductions of labor, increases in the frequency of non-hospital birth center and home births, reduction in unnecessary prenatal visits, increased reliance on remote health monitoring devices, and this literal explosion in the use of telehealth for prenatal and postpartum care. And to us, this seems to represent a really important value proposition, trading low-value care and practices for practices that have a stronger evidence base and that reduce risk. So amid all these good things that seem to emerge, there are, of course, many concerns about equity. What possible harms have this shift to telehealth caused? Some of the ones that came up most often in our discussions, of course, were the digital divide that many have covered well already, where folks do not have laptops or smartphones, or if they do, they might have limited Wi-Fi access or limited minutes or limited data plans. And of course, many poor urban and rural communities lack broadband internet access, so I'll skip over those. Language barriers, of course, are one of the concerns with equity. Women and families whose primary language is not English may not have the same access to telehealth, especially if their providers do not speak their native language or if interpreter services are limited. This is a concern that I think is exacerbated for vulnerable immigrant communities who face both language and trust barriers related to immigration and enforcement. Privacy, patient privacy issues came up a lot in our discussions, where mothers may not have private space to do their televisits. We had providers tell us about women taking visits from their car or in a closet or using chat boxes instead of the loudspeaker. We had providers express concern about what they might witness during a video call if they saw something illegal or unsafe or dangerous that would normally trigger mandatory reporting. They speculated that informed consent procedures might need to be incorporated in their practices, which might actually undermine women's openness to doing telehealth. Providers did also warn that all previous in-person care could not be replaced by telehealth. High-risk pregnant women need to be seen more frequently than low-risk, for example. And the convenience of telehealth should not outweigh patient preferences for in-person care. Patients should be empowered to ask for in-person care if they prefer. There were also concerns among providers that health systems might increase their use of telehealth for the wrong reasons, for example, to reduce cost. So turning to policy suggestions for promoting better equity in maternal health care moving forward. As many others have said, first, the federal and state governments could make permanent many of the changes that they have adopted as part of the public health emergency. For Medicaid, which pays for nearly half of all births in the U.S., payment parity, of course, would spur greater use of telehealth. We think it's really important. The providers we spoke with thought it was very important to expand the range of services permissible via telehealth that are critical to women who suffer disproportionate maternal morbidity and mortality. And here I'm talking about doula support, prenatal risk assessment, postpartum depression screening, home visiting, mental health and substance use counseling, and the like. Advances in telehealth really need to include all birth workers and not just physicians and institutions. Here again, midwives, doulas, community health workers, social workers, mental health and substance use providers all need to be able to provide and bill for coverage through Medicaid. And providers warned that cultural and ethnic and linguistic equity will suffer if these folks are left out of future policies. Payers could begin covering remote monitoring devices and even smartphones as DME, and governments, of course, could bolster the capacity of safety net providers to provide telehealth services. So let me just conclude by highlighting some of the research questions that we identified that will be critical to monitor in determining whether increased use of telehealth is hurting or harming. Some of these questions are: how does the increased use of telehealth affect outcomes and quality of care generally? How does increased use of telehealth affect maternal health equity specifically? Does it exacerbate disparate outcomes for Black and Indigenous populations, or does it help level the playing field? How do we ensure that cultural, ethnic, and language inequities are not exacerbated by telehealth? And then finally, in light of HIPAA rules, what privacy risks does telehealth pose, particularly for vulnerable populations such as people with substance use disorders, individuals with mental health concerns, and other stigmatized groups? We need clear, data-driven, and patient-centered answers to these questions if we're ever going to know whether the increased reliance on telehealth helps or harms our country's efforts to address maternal health inequity. So thanks a bunch. I appreciate it, everyone. Here's our contact information as well as a couple of links to our paper and our project. Thanks very much. I hope you found this helpful.
Wonderful. Thank you so much, Ian. We appreciate the work that you did to really help us. Can everyone hear me?
Yes.
Okay, wonderful. Sorry, I think my audio cut out for a little bit, but thank you everybody so much for those wonderful presentations, and I think we are going to go ahead and open up the floor for questions. Reminder to everyone that if you are connected via your phone, you can ask a question by pressing *6 to unmute, but we do ask, please, that you do not put us on hold. And if you are not connected by phone, you are more than welcome to put a question in the chat box. I will go ahead and get us started with a chat box question from Sophie. Sophie asks, many providers have seen a drop in no-shows. People that earlier were unable to attend scheduled appointments are now able to do so with telehealth. Has anyone seen quantitative research on who this is benefiting? I'll open it up to any speaker who really wants to take a stab at that question.
This is Ian. I have not seen quantitative research on that, but just to underscore your anecdotal experiences, that virtually all the providers we spoke with really did confirm that it was remarkable how attendance was improving for different types of care, individual prenatal care, group prenatal care, and it really came down to the fact that transportation was no longer a barrier. And childcare, finding affordable childcare was not a challenge.
Awesome. If neither of our other speakers wants to jump on that, I will go ahead and read another question that we have in the chat saying, is there any specific research on telemental health for suicide prevention, specifically targeting men? That is a very specific question. I personally do not know. If anyone has if any of our speakers have any info on that, I would encourage you to speak now or type in the chat box.
So this is Lee, and I'm not sure about specific research on suicide prevention, specifically targeting men. That is very specific. But there is a lot of research that shows that telehealth has great outcomes in the mental health space. So I'm sure, that is something that you could look at. If it's not specifically targeting men, I'm sure there is a study around suicide prevention and telehealth.
I would agree. This is Ian. The folks we spoke with talked about how telehealth may actually work better for some people, that the distance created by talking with somebody through a video call helped folks feel safer and open up. Clinicians talked about how they sometimes couldn't pick up on the nonverbal cues that are so important in direct therapy, but overall, we're pretty pleased with how it was working for them.
Wonderful. I'm going to go ahead and ask Ted's question. Dr. Kung's chart showing disparities was a 1-month snapshot in early 2020. Is there evidence about the persistence of these disparities?
This is Elaine. I haven't seen anything that's published with recent data, but I know that at least looking at our health system, that data initially was really in the beginning, and that was primarily when video visits were the only one reimbursed. Within our health system, where we are doing actually mostly telephone visits, we actually, when we look at our data, we don't actually have any disparities in terms of who is like the utilization. Like we had pre-existing disparities in utilization, and those are the same disparities that we continue to see. There was no disparities related to sort of if it was in-person care before versus telehealth care.
Wonderful. Thank you, Elaine. Ken Brannon asks, can any of the panelists give information on how to research state regulations on telehealth?
This is Lee. The Center for Connected Health Policy should be a good starting point for looking into state regulations on telehealth.
Awesome. Thank you, Lee. Jacob Goodman asks, do any of the speakers have insight into ways in addressing problems providers are currently facing with telehealth where patients are keeping appointments as they travel? Due to the patient no longer being in the same state, I've heard reports of providers having significant issues for reimbursement. Well, if no one has any input to add there, I will say that I think that there has been some movement at the federal level, at least in terms of Medicare reimbursement, to try to allow providers to provide care across state lines. And I do know that certain states are also moving in this direction in terms of licensing to allow providers to practice across state lines for telehealth. I don't have any concrete information or sources for you right now, but I can try to find some sources and get back to you if that's okay. And I'm going to move on to our next question here.
Sorry, really quick, this is Lee. Speaking to what you were already saying, Annalisa, some states have adopted the Interstate Medical Licensure Compact, and that helps us streamline the licensing process for physicians who want to practice in multiple states. So like you mentioned in the question, there are issues around licensure, and a lot of that is related to scope of practice laws that are set by state boards of medicine.
Wonderful. All right, let's move on. So Asia has two questions. One, as it relates to telehealth beyond the COVID pandemic, what are your thoughts on hybrid care post-pandemic? Is it possible to provide a link to the PCORI study on HIV patients from the first speaker's presentation? To answer your second question, we will be providing those links, and I will work with Lee to make sure that we get that, include that link on our email blast. As far as the first question, Elaine, would you like to answer that one, considering that you are a provider?
Yeah, I'd be happy to weigh in. I think at the end of the day, all of this is really focused on like what best meets the patient needs, and I think a hybrid model makes a lot of sense. And this is something that we think more and more about in primary care and in terms of moving care outside of really discrete in-clinic visits. So my hope is that, and I think it will happen, is that even after COVID and after whenever the pandemic ends and the need for only telehealth visits ends, I do think a hybrid model is what makes sense. There are certain things that I can do great remotely. I can check in on a patient's blood pressure if they have a blood pressure monitor and titrate up their medications, and they don't need to take like the two buses and a 1 hour and a half transportation over to come see me when I can do all of that remotely. But there's certain things that certainly require in person, and we'll bring the patient in. And I think what is needed is thinking about how do we provide the best type of care for each individual patient, and obviously providing the reimbursement and policies to really support that patient-centered way of thinking about hybrid care.
Wonderful. Thank you so much, Elaine. We have another question here. Are there any thoughts on the differential error rates due to clinicians being more likely to multitask while on phone calls compared to on video telehealth?
This is Elaine. This is, I think, an area of active research, and I know there's folks at UCSF that are thinking about this, looking at, electronic health record audit logs and seeing how often clinicians are, for example, ordering a medication and then quickly discontinuing it, suggesting that they accidentally ordered on the wrong patient or sort of made a mistake. I don't think there's anything that's actively studied yet, because the reality is that phone visits weren't really a thing until the last couple of months. But I think this is certainly something that people worry about, and I've definitely heard clinicians reflect on this themselves.
It's an interesting point. The only thing we heard from our research is kind of the opposite point, that telehealth was so new to so many providers that it required a great deal of intense concentration and focus. And providers were actually pointing to that as justification for payment parity, and even arguing that televisits in some ways deserve to be paid at higher rates. So we didn't hear, though, about the distraction issue, and I think that could become, as this becomes more and more routine, it's a really interesting concern to be looking at.
Wonderful. Thank you both for those thoughtful answers. I have a question that I was wondering if I could ask to all three of our speakers. How do you think telehealth can be used to address the upstream factors of health? And are you feeling optimistic about our ability to do that in a post-COVID world?
This is Lee. Oh, sorry. Go ahead, Elaine.
No, Lee, go ahead.
Okay. So this is one of the things that we had touched on in our report, is the importance of being able to reimburse different types of providers and patient support type folks for telehealth services. So thinking about community health workers and patient care coordinators and the types of folks that are really going to be, would typically maybe be in someone's home and be doing the screens for social determinants of health. Being able to reimburse for that is really important, and to be able to do that via telehealth. So I think that we, to a certain extent, can address more upstream determinants of health via telehealth, but things are going to have to change in reimbursement policy for that to happen.
I agree with that, and I think I think this goes back to, again, if we keep patients sort of at the center and thinking about how we can best help secure health outcomes, I am hopeful that we can think about ways that telehealth can address upstream determinants. I have a patient who is oxygen dependent and was reliant on somebody else for transportation. That person, was working, normal clinic hours, and so I really had a hard time seeing that patient during pre-COVID. And then once we switched to telehealth, I was able to check in on the patient sort of every month, basically. And so transportation was really a huge barrier for her, and that is one that, of course, telehealth is primed to help address. I think on the flip side, of course, for the patients who don't have reliable phone access or can't reliably charge their phone, us sort of being entirely in a telehealth world has actually been very difficult for them. And so I think, it's about thinking about, if this patient has a social need that is addressed by being able to provide services remotely, then I think telehealth can certainly address that, but certainly not forcing it upon folks who are better served by the type of care that we provide in in-person care.
Yeah, I would just concur with what both Elaine and Lee have said. The providers that were perhaps the least optimistic or at least excited by this shift were case managers, home visitors, community-based groups that really do more hands-on care and feel like being out in the community, in the home, is so important to being able to get at the full range of social determinants of health. They were extremely vocal, as were other providers, about the importance of defining future policies so that they could be paid for virtual care, the community health worker, the social worker, the home visitor. So I would just concur that that's a critical way to maintain an ability to deal with upstream issues moving forward, and that will be especially important in the equity questions around maternal health.
Thank you all. We have another question from Sophie, who says, on Dr. Kung's point, phone consultations appear to improve disparities compared to only video. This is critical for advocacy. Is there any quantitative research on this point? I will start off by saying that I personally don't know off the top of my head of any research on this, but also our speakers may know a little bit more than I do.
No, I don't know of any quantitative research. I would go beyond that to say, beyond just the telephone, that the doulas we interviewed talked about text messaging as being their primary mode of communication, 24/7, being available to chat by text, and they were really concerned about that being reimbursable.
I don't think anything, this is Elaine, has certainly been published yet, again, because all this data is in the making. I know that, we actively are, I'm actively sort of waiting for some data to be able to pull some data from our electronic health record, looking specifically at sort of phone encounters versus video encounters, and sort of looking at who's accessing those different types of visits. So I imagine there's probably lots of researchers sort of nationwide that are thinking about this question if they have access to that data, but I haven't personally seen anything published yet.
Wonderful. I think that may answer this other question we have from Anne, which was, does anyone have data regarding the quality of phone-only visits? I think that perhaps we're all a little too eager for that data. I'm not sure if any has come out yet. But at this point, I would like to ask another question, if that's okay with everyone. I guess I'll ask this to all of our speakers. Do you know of any particular states that are giving us a real positive example when it comes to creating equitable telehealth policies?
We highlighted in our report California and New Jersey and North Carolina. They were doing similar things, but essentially around payment parity, using state regulations to require parity, with private insurance payers as well. I'm looking back at my report real quickly, allowing billing for prenatal, postpartum, maternal support services, depression screening, a lot of that important stuff for maternal care. But I'll let others weigh in.
This is Lee, and I was also going to say California, so I just echo the states that Ian had mentioned.
It seems like California is so often the golden child. Oh, sorry, Elaine, go ahead.
I was just going to weigh in as a clinician in California that we certainly have been able to reimburse for phone visits, and that's really allowed us to be able to provide that to our patients. I think if we weren't able to do that, that would have been a huge difference for our patient population.
Wonderful, yes. Let me see. One more question that I have is that, are there any particular telehealth breakthroughs that you're excited about? I'm going to pick on you, Elaine, since you are a provider, and I'm wondering if there are any breakthroughs, maybe technology or something that you have either experienced or heard about that makes you hopeful for the future.
Yeah, I think the breakthrough is simply actually just like the level of adoption, which is the most exciting part, and thinking about the remote patient monitoring and the investment that a lot of health centers and systems are doing, and thinking about how do we actually provide care to patients remotely. This is not a technology breakthrough from the standpoint that, this technology's been around, it's been available for a really long time, but I'm finally hearing conversations about how do we actually adopt this, how do we actually implement this and keep this available for our patients. And so I think, breakthrough in the sense that we're actually adopting something that's been feasible for the last 10 or 15 years. Healthcare is notoriously really slow to adopt technology, and so I'm excited that people are putting in and developing the infrastructure and thinking about the workflows and the way to support actually using telehealth, and in particular for me, thinking about remote patient monitoring, thinking about a lot of chronic disease management that is of course better managed between these sort of every 3 to 4 month visits, but continuing that type of care in between visits.
Wonderful. Awesome. Thank you so much.
Mm-hmm. I would concur, that the notion that there can be a silver lining from the COVID-19 pandemic is hard to consider, but the adoption has been incredible, and the success is very promising and exciting. I also think that the value proposition, I'll be really interested in your next webinar, as I pointed out in my presentation. For decades, folks have been trying to push the birth center movement, midwifery care, non-hospital, reduce intervention type care for pregnancy, and then suddenly, almost overnight, people were saying, "Hey, we can do these births outside of the hospital. Let's cut down on visits." So it's the idea that this could happen quickly. I think has a lot of promise for maternal care.
Terrific. Well, what a great question to end on. Thank you all so much for those thoughtful questions and equally thoughtful answers. As we wrap up, I would like to give everybody access to these 2 resources that the Hub personally has, a research brief about telemedicine, and then also a health equity glossary that will be made available to everyone after the webinar. And I just want to note, Stephen, that we will go ahead and include that study that you emailed to us in with the resources that we will be sending out to everyone. So do not fear. That was a great study, and we definitely want everyone to have access to it. So I would like to conclude by saying a big, big thank you to our wonderful speakers. Thank you for your thoughtful takes on this, really new topic, new and complicated topic. I'd also like to say thank you to our funder, the Robert Wood Johnson Foundation, as well as all of you participants who took an hour out of your Friday to spend with us talking about sort of a wonky subject. So thank yous all around. And yeah,